Thank you very much, Gary. So I know everyone complains about the titles that they get from David, but what would you do if you were sent this and asked to write a lecture about it? So I thought about what I could do with this, and I thought I'd better start for those who are not Americans and under the age of 50 or so, telling you that there is a character called Gentle Ben, which is a bear, and this was from a television series which was adapted from a book about a child who lived in the Everglades with this bear. And remarkably enough, this group of TV performers actually put together an album called The Bear Facts. So I guess maybe David had more method to his madness than I had realized. So I'm still stuck with what to discuss, and I said, well, I'd like to talk about molecular microbiology, and I said, no, can't do that. I talked about it last year. I'd like to talk about osteomyelitis. Can't do that. Professor Jeffcoat's going to do that next. How about new antibiotics? That's a topic I always like to talk about. Unfortunately, Warren grabbed that before I could. How about bacteriophages? This is a new area that William Jeffcoat is submitting a grant that I'm one of several collaborators on. But we have a real expert. Professor Cutter is going to speak about that. And so I picked 4 areas that I'm going to try and get through in the 20 minutes allotted to me. One is to give you some new real data on the Codified Study that I mentioned briefly last year. One is on looking at MRSA and asking the question, is it really different from other pathogens? The third is looking at the role of anaerobes. For a long time, I've thought that anaerobes may not be as important as other people have. And finally, to talk about antibiotics and their role or lack of role in wound healing. So let's see if we can run through these. Let's begin with the Codified Study. It stands for Concordance in Diabetic Foot Ulcer Infection. And a brief reminder to those of you who didn't hear the couple of things I had to say about this last year. Patients with an infected diabetic foot ulcer using IDSA criteria were recruited throughout England. By doing a power calculation, we decided we needed 400 patients. Primary endpoints is what is the agreement between a wound swab and a wound tissue specimen for a variety of microbiological findings, as you see listed there, as well as for antibiotic resistance, and a number of secondary endpoints, including the appropriateness of empiric antibiotic therapy that these patients received, the adverse events and costs of the 2 different ways of getting specimens, and the long-term outcome for infected diabetic foot ulcers. Remarkably little has been written about what happens after you cure a patient with a diabetic foot ulcer if you follow them over a period of time. And then finally, we did a small subset analysis looking at the difference between PCR and standard culture methods. So as far as results, this group of patients was similar to most studies of infected diabetic foot ulcers. They were mostly men, mostly middle-aged, mostly type 2 diabetes. The median ulcer duration was almost 2 months. They are approximately evenly split between neuroischemic and neuropathic ulcers. We did do Wagner grades, even though I'm not a fan of the system. 1/3 were Wagner 1s, 1/3 2s, 1/3 between 3 and 5. Interestingly to me, 60% of the patients when they came into this clinic and were enrolled in the study had antimicrobial dressings on their wounds. And not surprisingly to me, almost half of the patients had already received some antibiotics at the time that they presented with an infected foot ulcer. We looked at what the likely pathogens were, and we had to decide what was a likely pathogen versus a contaminant, and I won't go into the details on that, but as is seen in most Western studies, as I spoke about last year, about 70% of the organism were aerobic gram-positive cocci, Staph aureus being the most common, and in the UK there isn't much MRSA. Gram-negative bacilli in a little over 1/3. We saw anaerobes in about 20%, a little over 20% of the patients, and I'll come back to that because that's actually a higher figure than I might have guessed, although we made a specific effort in the microbiology laboratories to look for anaerobic organisms. So what were our overall summary data like? No pathogens found in 30% of the patients when a swab was sent. Remember, every patient had both a swab and a tissue, and half as often did that occur in patients who had tissue specimens. And 2/3 of the time with a swab, when they didn't have any pathogens, nothing was isolated. The other 10% were contaminants. More than one pathogen, more frequently with tissue. Mean number of pathogens, 50% higher on the tissue than on the swab. And twice as often were you going to have a contaminant on a swab than you were on a tissue. Moving along for other data, swab and tissue reports the same isolate only 42% of the time. In the in the instances, the majority of instances where the swab and tissue were different, the most common thing we saw was that the tissue reported additional isolates compared to the swab. So the swab was neither sensitive nor specific when compared against the tissue isolates. Now, looking at another interesting question, which is, were the pathogens sensitive to the antibiotics that the physician selected empirically to treat these patients? And when you did a 2x2 table comparing swab and tissue, I'd like you to just concentrate on the red box there, which says that almost 42% of the swab pathogens were not sensitive, but almost 53% of the tissue. So the tissue more often showed you organisms that were resistant to the empiric antibiotics that you selected. We then had a panel of clinicians who we asked to look at the clinical data, look at the microbiology results, and decide whether you think the patient got the right empirical therapy. Again, a 2x2 table, and what they said was that looking at the results of the tissue, 44% of the time the docs got it wrong. Looking at the results of the swab, it was 35% of the time. So once again, tissue appeared to show more pathogens that a blinded panel of clinicians thought were important to treat with antibiotic therapy. So the summary that I'd like to suggest to you is that swab but not tissue indicates a need for a change of therapy in a small percentage of cases, but it's much more common that tissue indicates a need to change therapy. And if you combine the two together, almost 75% of the time, the clinicians had selected what appeared to be an inadequate antimicrobial treatment for these patients. How about the long-term outcome? Here you see 1 year after we enrolled the patients, and if you compare healing against what's called competing risks, which is epidemiology speak for people who got amputation or died, only 45% had long-term cure. The other patients had either an amputation or death. One of the interesting things we looked at was, what about if the patients were Pedis class 2 or mild infection versus Pedis class 3 and 4? And you can see that there's a clear separation between these two groups, once again suggesting validation of the IDSA and International Working Group classification scheme, differentiating moderate from severe infection. So I'm going to just move through this one because I want to not take too much time because we're squeezing in one extra lecture here, and move on to a quick discussion of the results. This is a pragmatic study that reports the real-world collections and reporting system. Remember that the results that are reported to you by your clinical microbiology lab start with collection of the specimen, then move through transporting the specimen, plating it, doing the culture, and evaluating the results, and then the microbiologist deciding what they want to put on the report. So there's a lot of places where the results can be tampered with, if you will. Does the increased yield from tissue samples that we clearly showed represent a better performance of tissue specimens, or simply that microbiologists tend to report more information when they have tissue in front of them than when they have a swab in front of them? We can't actually answer that question. And then you could certainly ask, does this matter? I think the fact that you would change your antimicrobial therapy based upon the results of tissue culture far more often than you would on the basis of swab culture persuades me that what we've advocated for many years is that we ought to be getting tissue. Well, that means the next question is, can we change practice? And I think we can. My hope is that when you convince patients, convince clinicians with data, that they will do what the right thing is. Okay, a quick discussion about the question of in DFI infections, is infection with MRSA really any different from with other organisms? This is a paper that we just published a month ago asking that question. Do diabetic foot infections with methicillin-resistant Staph aureus differ from those with other pathogens? Warren is going to talk a little more about this in a moment, but what we did was a non-systematic review of the literature looking at diabetic foot infections from anywhere in the world. We found 48 studies from 28 countries between 1999 and 2013. We had data from over 7,700 patients. Staph aureus represented 30% of the diabetic foot isolates, and 37% of the Staph aureus were methicillin resistant, representing 1,656 cases. Median duration of antibiotic therapy was 26 days, 10 days of which was IV, but the key issue is that there was no difference that we could find in either the clinical presentation or the outcome if the patient had MRSA or MSSA or any other pathogen. So we could not find any evidence in the literature that MRSA actually behaved any differently, even though people worry about the so-called superbug. Okay, MRSA, time from colonization to infection. An interesting paper that I found when I was looking into this, a study that looked at 840 inpatients, and they said from the moment we've documented that they are colonized with MRSA, how long does it take before they get infected, and how often do they get infected? Sorry. And the answer is that only 14% of the colonized patients became infected with MRSA, and it took an average of about 3 weeks. Interesting piece of information. Let's move on to the third issue I wanted to cover, which is the role of anaerobes in diabetic foot infection. So the history of that is we've long suspected that anaerobes play an important part in diabetic foot infections. Before we called them DFIs, they were called a diabetic gangrene. And if you go back to the literature of the 1930s, these patients were hospitalized. 60% had an amputation, almost always above-knee amputations because the surgeons feared that infection would spread below. And the mortality rate was 10% in these patients. So there was thought that anaerobes played an important role because of the smell, the appearance, the gangrene, and so on. The first paper, however, to document this was a very famous paper by Louis that was published in 1976. If you look carefully at the paper, there were only 20 patients. Never said in the paper whether these patients had an infected ulcer or a clinically uninfected ulcer. That term wasn't really defined back then. Among the 116 isolates, almost 6 per patient, and a slightly greater percentage were aerobes than were anaerobes. The principal isolates of anaerobes were Bacteroides and Peptostreptococci. When antibiotics were needed, they said you should consider covering both aerobes and anaerobes, and that was the state of the art for quite a while. In 1980, Sapico did an interesting study. He went to the OR and took 13 legs that were amputated for a diabetic foot infection, brought them to the microlab, and did a variety of different culture specimens from them. The thing he was trying to demonstrate is what's the best way to culture, and he found that the best way to culture was with a tissue specimen compared to an aspirate or a swab, which we've obviously just spoken about. But he also found about 5 bacteria per wound and about even split between aerobes and anaerobes. In 1995, Dale Girding looked at the literature. He's a person who spent his life studying anaerobes. He said that anaerobes were found mostly in deep, severe ischemic wounds, but their true frequency was still unclear, and the clinical significance of anaerobes in an isolate were also unclear. And that's the end of the literature, really, until recently. So what we decided to do was to look at this question and review the role of anaerobes in diabetic foot infections. We started by doing a literature search. We did a systematic review of the literature, found 44 epidemiological and interventional trials with 13,000 patients. The unweighted average of anaerobic pathogens reported in these papers was 12%. If you did a weighted average, weighting for the number of patients in the study, it was about 8%. You can see a very wide range. The main isolates were the ones that I've already mentioned to you. There was no evidence of worse outcomes when anaerobes were grown than when they were not grown. We then decided we would look at the University of Geneva, where I work part-time, and we said, let's go back for the last 10 years and look at all of the patients with diabetic foot infections and compare patients who had anaerobes and those that did not have anaerobes on culture. We had 517 patients with well-documented diabetic foot infections. Anaerobes were only found or reported from 3% of the patients. So is that a suggestion that anaerobes are infrequent in Geneva? I think it probably is a representation of the fact that if they're not looked for, they're not found. If they're not found, they're not reported. When they were found, they were always part of a mixed infection, and this is true in almost every paper that's been published. It's extremely uncommon to have a purely anaerobic infection. In terms of quantitation, they were the main pathogen in only a few of the cases. They were mostly the 3rd, 4th, or 5th pathogen found. And again, anaerobes were not related to the risk of treatment failure, as I had reported previously, but they were associated with a need for minor amputations in patients who had ischemia. Now, whether it was the anaerobes that caused the need to do an amputation or whether the ischemia allowed the growth of anaerobes, we can't tell from the data that we have available. Okay, so now I want to switch gears to another topic, which is I was asked to give you the bare facts of infection, and I was trying to think, well, how do I represent that? And I thought about, well, when you do home repairs, how do you approach doing a home repair? And I asked the question, when I'm faced with something that's not working, does it move? And the answer is no. Then I say, should it move? And if the answer to that is no, then no problem. If it should move, the answer to that is yes. Well, WD-40 is the answer, okay? And if the answer is, does it move? Yes, it's supposed to. Should it move? Yes, no problem. Should it move? No, duct tape's the answer. So it's pretty easy. I'm trying to find a way of presenting infection in as simple a manner. So what's an approach to antibiotic therapy for diabetic foot infections? Is the wound clinically infected? No. No antimicrobials? No problem from the antimicrobial point of view. Is the wound infected? Yes. Is it a severe infection, or has the patient recently had antibiotic therapy? If the answer is no, then just cover aerobic gram-positive cocci, and the vast majority of patients will do fine. If the answer is yes, it's either severe or they've had antibiotic therapy, then the initial therapy should be broad spectrum. You should cover MRSA where that's a prevalent pathogen. Pseudomonas only if the patient has high risk factors for Pseudomonas. For example, you're from a hot country where Pseudomonas is common. And in both instances, you then tailor the therapy based upon the results of the cultures and sensitivities and how well the patient is doing. So I think that's a fairly simple, straightforward approach to infection. Next question I want to deal with is bacteria in wounds may impair healing, but should we treat them all with antimicrobials? So looking at antibiotics used in non-healing wounds, there was a study by Gergen that was very interesting. It was a prospective observational study done in 2008. They looked at 105 patients who were primary care patients referred to a wound clinic in Norway. And these were the different kinds of wounds that were referred. And the question was, what about antibiotic therapy? And it turned out that 75% of these patients who had open wounds were treated with antibiotic therapy. And they got the antibiotic therapy before they were then referred to the wound clinic. When the wound clinic saw them, they agreed in only one case that antibiotic therapy was actually needed. Now, it's possible that the antibiotic therapy they got changed the way the wound looked by the time the wound referral center saw the patient. But I think there's a strong inference here that we're using way more antibiotics for wounds than are absolutely necessary. Is there any better data than that? Well, there is some interesting data from Sweden. Sweden set up a national registry of ulcer treatment for what are called hard-to-heal wounds. Most of the wounds were leg and foot wounds, some were pressure ulcers. They set this up in 2009. It's a web-based quality registry, and it's designed to provide structural checklists for optimal treatment to teach doctors and other clinicians taking care of the patients by going to the web, how do you take care of these wounds, and to capture evidence about how the patients are being cared for and are they getting better in areas where they felt they needed improvement. They covered primary, community, and hospital care. The median adjusted healing time changed from 146 days in 2009 when they started this registry to 63 days in 2012, a dramatic reduction in the number of days it took to heal wounds. Now, I was particularly interested in the issue of antibiotic therapy, so let me show you the data on that. Each year from 2009 to 2012, they looked at whether the patient was getting antibiotic therapy at the time they were put on the registry, and then whether or not they continue to stay on antibiotic therapy when the clinicians looked at the registry and looked at the suggestions for when antibiotics were necessary. And the vast majority of the time, they took them off the antibiotic therapy and still had better healing outcomes without antibiotic therapy. Antimicrobials for treating venous leg ulcers, a related partner to diabetic foot ulcers. We recently did a systematic review of the literature. It was done as a Cochrane review and then published in the Journal of the American Medical Association. The bottom line is, looking at the 10 available studies, there's no evidence that antimicrobial therapy hastens the healing of venous leg ulcers or prevents any complications. Another study, another group, the EUMA, which is the European Wound Management Association, which tends to use a lot of antimicrobials for treating their patients. If you look at their recent document published in October of 2014, they say there's no proof that routine administration of antibiotics is effective for prophylaxis or treatment of non-infected, non-healing wounds. And the most important endpoint with regards to antimicrobial treatment should be the prevention of infection and the resolution of infection. So they're along with us on this. So we published an expert opinion that we were asked to write, with the title, "In Diabetic Foot Infections, Antibiotics Are to Treat Infection, Not to Heal Wounds." And we did this based upon a non-systematic search of the PubMed literature from the onset of when papers were available in 1951 through November 2014. And based upon our review of that literature, we had concluded that there was no good evidence that antimicrobial therapy prevents infection in uninfected wounds or makes wounds heal faster. So, treating diabetic foot infections, what are the barest steps to appropriate therapy? Send optimal specimens, which I think are clearly tissue, not swabs. Use as narrow a spectrum of antibiotic as possible, and you usually don't need to treat with anti-anaerobic agents. MRSA infections are similar to MSSA, so I don't worry as much about getting patients on anti-MRSA therapy unless there's a high local prevalence. Give antibiotics for as short a duration as possible. Maximize non-antibiotic approaches, and do not treat clinically uninfected foot wounds. So that's the 2015 edition of the Bare Facts of Infection from Gentle Ben. Thanks very much.